Good afternoon. Thank you for joining us for our panel about persuading skeptical audiences to support HIV prevention. My name is Chelsea Boyd, and I am a research fellow in the R Street Institute's Integrated Harm Reduction Policy area. For those unfamiliar with R Street, we are a nonpartisan, nonprofit think tank based in Washington, D.C., and the Integrated Harm Reduction team focuses on all things harm reduction, including illicit drugs, tobacco, and sexual health. Before diving into our panel discussion, I want to provide a very brief overview of HIV and AIDS in America. First, there has been tremendous progress in understanding and treating HIV since the first cases of AIDS were documented in 1981. What began as an untreatable illness has become a manageable chronic condition for most people living with HIV. Since the Food and Drug Administration's 1987 approval of AZT, the first pharmaceutical treatment for HIV, new drugs that treat and others that prevent HIV have been developed. These added to the arsenal of methods that prevent new HIV infections. This was a welcome addition since for many years, condom use and safe injection for people who use drugs were the primary forms of prevention. These tools remain extremely important, but now we have new tools in our toolbox. One game changer was the discovery that undetectable viral levels mean HIV is untransmittable, making HIV treatment an essential part of HIV prevention. The development of pre and post-exposure prophylaxis, medications that prevent HIV transmission, has been an important piece to the puzzle as well. Although there is a lot to talk about related to HIV treatment and management, today's presentation will primarily focus on discussing HIV prevention. While a variety of methods are available to prevent HIV, it is challenging for many individuals to access preventative care. Barriers to accessing care contribute to the roughly 32,000 new HIV infections that occurred in the United States in 2021. Although this is a 12% decrease from the number of new infections that occurred 5 years prior in 2017, it's a long way off from achieving the Department of Health and Human Services 2019 ending the HIV epidemic goal of reducing new HIV infections by at least 75% by 2025 and at least 90% by 2030. One of the challenges with prevention is that individuals and community leaders need to be convinced that they should be concerned about HIV as a pressing priority before you can get them to focus on prevention. At the individual level, HIV does not discriminate based on sexual orientation, race, ethnicity, gender, age, or geography. Although anyone can be affected by HIV, some communities are disproportionately affected. Stigma and barriers to accessing prevention tools contribute to these disparities for some communities. Men who have sex with men, particularly those who are Latino, Black, Indian American, or Alaskan Native, Black women, transgender women, young people under the age of 24, and people who inject drugs belong to communities who are disproportionately impacted to HIV. It's important to remember that communities disproportionately affected by HIV do not necessarily engage in higher risk activities. Their increased risk is at least partially due to the higher concentration of individuals with HIV who are not adequately treated, and thus able to pass on the infection. Another important thing to remember is that although some communities are more impacted by HIV, that doesn't mean that HIV can't happen to people outside of these communities. Unfortunately, it seems that the "it can't happen to me" mentality is seeping into the public discourse more often. Although ultimately, preventing HIV comes down to individual actions, policymakers and community leaders can make it easier for folks to access and use available prevention methods. Unfortunately, we're seeing some troubling signs that some policymakers no longer see HIV prevention as urgent or worthwhile. For example, during the debate where the city of Pueblo, Colorado banned syringe service programs, one city council member compared HIV to the flu, minimizing its severity and the impacts on the community in order to promote a policy that would ban a proven HIV prevention intervention. While this statement is alarming, it also is a signal that more education and persuasion can help turn the tide. Misunderstandings and lack of awareness about HIV are what brings us here today. Our esteemed panelists have extensive experience communicating to and achieving breakthroughs with skeptical and misinformed audiences. Today, I will facilitate a conversation about breaking through skepticism to have meaningful conversations and drive policy change that supports HIV prevention. With that, I will introduce our expert panel. First, we have Tony Newman, who is the director of the Coalition for Justice and Equality Across Movements and the acting director for the Training Center to End the Epidemic at NMAC. She was previously the interim CEO of the Black AIDS Institute and interim president of the Lyric Youth Foundation. Tony is a faculty member at the Transgender Strategy Center and the chair of the board of directors for Trans Can Work. Next, we have Senator Megan Hunt, and she is a member of Nebraska's unicameral legislature and represents a district in Omaha. This year, Senator Hunt built impressive bipartisan support to pass a bill authorizing syringe service programs in her state. While the bill was ultimately vetoed by the governor, Senator Hunt did important coalition building work within the unicameral legislature. Senator Hunt is a small business owner and a sixth-generation Nebraskan. Next, we have Catherine Wells, who is the Director of Public Health for the Lubbock, Texas Public Health District. Catherine has spent most of the past decade rebuilding the public health system in this West Texas community and is currently launching a new HIV clinic for treatment and access to PrEP. She is a board member of the National Association of County Health Officials, and she is currently pursuing a doctorate in public health leadership at the University of North Carolina. Thank you all for joining us today, and I'm going to dive into some questions. So let's start by hearing from all of our panelists about what perceptions and misperceptions people currently have about HIV. Catherine, in your community, what is the level of understanding, including any misperceptions about the state of HIV?
In our community, we really, individuals or community members really think that HIV doesn't exist anymore. It's not something that physicians in our community think about testing for. It's something that I don't see a lot of people having conversations about prevention, but we're starting to see increases in the number of new HIV cases. So one of the goals of our health department is really trying to raise awareness, both in what we do as a local public health department, but also influencing what physicians and our medical community thinks about HIV.
Thank you so much for that. And Senator Hunt, in your work to pass bipartisan syringe services bills in Nebraska in 2023 and 2024, what did you learn about lawmakers' perceptions and misperceptions about HIV? And was there any sense of urgency among lawmakers about HIV in your state?
You know, first, thank you so much for having me be a part of this panel. And I'm interested in what I can contribute to this conversation as a policymaker because, you know, I'm obviously not coming to this discussion as an expert. I don't have a background in healthcare or public health work or anything like that. I just care about it. And I work with a lot of policymakers who care about it. But I come into it with a degree of ignorance, you know, and hoping to learn, of course, but a lot of my colleagues come in with that same ignorance, but they are not as willing. And that's something that's really frustrating. There are many different public health districts in Nebraska, and all of them are seeing increases in incidences of hepatitis C, Hep B, HIV diagnoses, things like that. And we know from other communities around the country and around the world that the way to stop that is an array of preventative measures, including safe syringe programs like have been successful in many other communities and that we had the opportunity to do here in Nebraska. I will tell you honestly, I'm sure that every body of lawmakers is different because we're just different individuals, but the concerns of my colleagues were more political than they were practical. You know, there was a lot more concern with the relationship with the governor who vetoed the bill, or how will this make me look for my reelection, rather than thinking seriously about the outcomes for our constituents, the trust that the people who have sent us to do this work have put in us to, pass policy that will make them more safe, that will make our communities more healthy. Um, so for me, I mean, a lot of the convincing that we had to do to get this bill passed in the first place for the syringe programs, it wasn't even about like, let's look at the statistics, let's look at the evidence and the data and show how this really helps people. It was about, here's how I can make this politically advantageous for you. And that is too bad. That's unfortunate, but I can talk more about that, as we continue about just the political strategy of it, I guess.
Absolutely. Looking forward to hearing more about that as we talk more about how to actually have these conversations. And Tony, what beliefs have you encountered in your work about where the HIV epidemic is today?
I think well, it's morning in California, so good morning, everyone. I know some people on the East Coast. I'm on the West Coast in Los Angeles, but I would like to say I think there's 6 key elements on that, and I'll go very quickly on that. Global awareness and efforts. I think many people believe that the awareness and global efforts to combat HIV and AIDS have kind of significantly improved over the years, leading to better prevention, treatment, and support systems. Regional disparities, as we know, the South, for people of color, Latin and Black women, trans women of color, Black and Latin men, they're still experiencing high rates of HIV transmission and poor access to healthcare and education about HIV prevention. And there's also been a lot of treatment advancements. A lot of people believe in the significant advancements that people are not dying, but it is a manageable chronic condition. And my specialty is stigma and discrimination. There remains a belief that stigma and discrimination against people, especially people of color living with HIV and AIDS, still persists mainly in the South, hindering efforts for prevention. And some of the emerging challenges are such as drug resistance. People believe that the new challenges are what are the drug resistance and the impact of social economic factors continue to pose threats. And last but not least is the youth and education. There's a focus on the importance of educating, especially our youth, about HIV prevention, safe sex, and talking about PrEP in the communities of color. So these beliefs kind of, I guess, highlight something like a complex landscape where progress and challenges coexist. We made a lot of progress, but this is a disease and we have a long way to go. So I would like to let people know that even though my bosses, I've worked at a lot of AIDS institutions, they've had it 30, 40, 50 years. It is still a chronic disease and we have not found a cure. So keep that in mind. There is still a long way to go.
Thank you for that, Tony. I think those are all really good points, and especially talking about young people and educating them so much is very important, especially since young people are one of the disproportionately impacted communities. So I want to chat a little bit about what skepticism you're hearing from policymakers who block or roll back efforts to combat HIV, and what are they? How are they reasoning this? What's their rationale for doing so? Anyone who wants to jump in for this can go ahead.
There are 3 things: political beliefs, religious belief, and budgeting. They say there's no money, or that they've been spoken to by God, and this is just not of God. And their political beliefs, which consist of their moral beliefs, that they think a lifestyle, such as a trans lifestyle, that I am a trans woman of color for 30 years. They think that's a wrong lifestyle, and I have swayed off the track of what God would have me do. So those are the 3 major ones that I encountered when dealing with people on the Hill about HIV and about trans women of color as well.
I think Ms. Newman said that very well. I completely agree. And that's been my experience working with policymakers as well. Not just, on the microphone, in public, in the press, in terms of what we say publicly, but also in these like private conversations. I had many of my colleagues come speak to me privately in my office and share their, similar views to what Ms. Newman said, of like, I just don't believe in this type of thing. And just kind of a deeply held, highly ignorant and discriminatory belief that people who have AIDS brought it on themselves somehow, or people who live with HIV are to blame for it. But this is also a thread you see through lots of challenges in society, whether it's people who need food assistance or people who struggle to find housing or people who lose their employment. Like, it always has to be something that they did where they deserve this. And it's a punishment from God or whatever it is. But what what has helped with that, even, and this is extreme, obviously, we do have more moderate people who do have concerns about budget, or who just have ignorance about, they don't realize what a big problem it actually is, and they're skeptical because they're ignorant, not because they are fundamentally against it. And then that's great because it gives us an opportunity to just bring in education, bring in those statistics and that research, and very importantly, bring in community leaders who they trust, such as like Ms. Wells, like their public health officials in their districts where they live, or healthcare workers from their districts where they live. One thing that my office has worked hard strategically to do is connect lawmakers with their own personal doctors, going to our healthcare institutions and saying, who's Senator Merman's doctor? Who's Senator so-and-so's, physician that they go see? Can we have them talk to her? Can we have them talk to him? And that has been very impactful. And working with conservative Republicans, I try to find a conservative person to talk to them, and vice versa, because as a lawmaker, I'm a progressive. I have a reputation as a very far left person in my body. And so there are folks I work with who just kind of aren't gonna trust me or listen to me because they have preconceptions about my agenda. So a key thing is finding people who lawmakers trust to be the right one to deliver that message, and leaving my ego out of it, leaving our own individual egos out of it, and saying, if we want to pass this policy, if we want to get these syringe service programs to work, maybe I'm not the right messenger, and that's okay. And how we're going to figure out how we get there.
That tip about having their doctors talk to them is such a good one, especially because personal doctors are still so well trusted by most individuals. Catherine?
Yeah, and so important about that right messenger. I find when I'm working with individuals, if I can find that right messenger to tell that story, it's so much more impactful. But there's one thing that Senator Hunt said early on about kind of the concern about they're focused on the political versus the practical. Even in local politics, I see that, because a lot of individuals that are running for some of our local representation have, they want to run for state office or higher office, and they're very concerned about looking like they sometimes support a more liberal agenda. So I do face that a lot. And then we also have a lot of just blaming the individual versus seeing, HIV and other chronic diseases as really being a cause of where you're living. And there's so much other social things that are going into those individuals becoming HIV positive, or even with other chronic diseases, that it's really that we need to work socially and across the board to help with the prevention part, and not just focus on individuals and saying, well, that person has this belief and I don't agree with them, or, they're not religious enough, or it's their fault. Really trying to convince them to look at the whole community as a whole. And it's so important to keep that viral load within our community low to prevent transmission.
And may I add one thought to that as well? This is the case with many politicians and policymakers, that they don't see the urgency of an issue until it hits them, until it hits their home or one of their loved ones or one of their constituents who comes and talks to them. And that's why storytelling is so important. That's some of the work that organizations like Art Street helps with, other community-led organizations that are more at the grassroots level. We need people who have the courage and strength to come speak to their policymakers, so that folks understand, you know, again, whether we're talking about food security or housing or sexual health or, you know, addiction or whatever issue it is, whatever diagnosis people have, um, that policymakers don't have to have experienced that personally to care about it. That they can say that they know someone who's going through it, that they're a good person, that they deserve better, and that they see themselves then as a lawmaker as finally part of the solution instead of someone on the outside who, you know, then that gives them cover to say, well, this isn't actually a big issue. This is only impacting a small number of people. And the storytelling that folks on the ground can help with is so urgent and important to that.
That's all such a great point. And also, I think that that it won't happen to me or it won't happen to someone that I love point is something that keeps coming up more and more in the conversation about HIV and this kind of othering of folks who are HIV positive or who have different life choices that they've made. And so now I'd like to talk a little bit about how each of you have been able to convince people that HIV is worth being concerned about, even outside of their actual or perceived risk. So first, we'll start with Catherine. And what conversations have you found to be most persuasive to policymakers, bureaucrats, and the public in getting HIV prioritized in your community?
I think it comes to the storytelling. We had a very sad story of a Hispanic woman in our community that was married, was very sick, had diabetes and some other comorbid conditions, and she kept going to the doctor, and she went and saw 5 specialists in our community and had, you know, someone thought she had a tumor in her brain, so they did a full neurological workup. She went and saw the endocrinologist. She did all of these workups, but nobody thought to test this woman for HIV. And it turns out that she had probably been living with HIV for at least 15 years, and she had full-blown AIDS, and she passed away before they got that HIV diagnosis back. And I tell them that story that this happened in probably 2015, that nobody in 2015, 2020 should be dying from HIV. Like we should be testing individuals in our community and catching people early, regardless of who they are. And that story has allowed me, unfortunately, I mean, I hate that she passed, but that story has allowed us to make a lot of changes in our community to really push forward and allowing us to open up some true prevention services and an HIV clinic that launched about 2 weeks ago. And we're even starting a hepatitis C clinic, which has never been available to individuals without insurance in our community. So it's the stories, it's talking, but it's also having the strength and feeling like you need to continue to pass on those stories and tell people about those individuals living in our community.
I really do think that there's so many people who have started to think that HIV is no longer something that needs to be worried about. So, or that because it's preventable or because it's treatable, that it's not a concern to the community. And so having that kind of a story is really quite impactful and of course sad as well.
Yeah.
Tony, you have an uncanny ability to shift conversations away from individual identities and groups and towards building shared humanity and empathy for anyone impacted by HIV. Can you talk about how you do that and the context of getting people to support HIV as a policy issue?
I have had some good luck with that, and I always take the focus off of me, and I also am not very offended. I'm a very open person, so I start off by highlighting personal stories. If I'm speaking to a group of Jewish women, I bring a Jewish woman who may be HIV positive. If I'm speaking to youth, I bring a youth who's HIV positive. I find personal stories with people who are HIV positive, talking to groups that they are a member of is very, very good. They tend to accept it better, understand it better, and I now know how to navigate and remove myself as the key person. As Senator Hunt says, sometimes they can't see my message because of who I am. So I make sure whatever room that I'm going into, I have the right messenger because I think that's key. And focusing on health, universal health and rights. At the coalition at NMAC, our theme is everyone deserves health care regardless of race, sex, and gender. This is like cancer. This is a disease. Don't you think someone who's HIV positive, who's an American citizen, deserves to get good quality health care? Very few people, even the far right, will say, no, they don't deserve health care. Everyone can agree that every American deserves to get good health care. So I use that common theme when I'm approaching people who may not have my political belief on how to move forward. And you got to address stigma and discrimination. We've got to address why that you feel the way you do. I always ask, you say that you don't like transgender folk. Have you ever met one? Have you ever had dinner with one? I'm more than happy to go to dinner with you and answer questions about why I did what I did 30 years ago. So I open myself up as a canvas so people can ask questions. I'm from a very Christian religious background from North Carolina, two religious parents. I understand the religious belief system, the Bible and Christianity. But at the end of the day, I say it's all about love and caring for one another. And how do we do that better? And last, I am a data person. You have to promote evidence-based solutions. If you're going to do this, I give them data. And I'm like, this is the data. And I didn't make this data up. Harvard, Yale, Princeton, Wake Forest University, my alma mater, they made this data up. So they tend to like, oh, I think you went to Princeton, did you not? Well, this is what Princeton said. They tend to gravitate toward data and identify with their alma mater or someone from Princeton. I always try to bring a messenger that someone can accept. And that is not always me because sometimes there's a block. Either because I'm Black or I'm a trans woman of color. I've been in a relationship for 20 years. How is that possible? I remove myself so that people can really get the message and simplify it as everyone deserves health care. And I'm not asking for anything special. I'm just asking for equal rights. That's all I'm asking for. Do you think I deserve that as an American citizen? I've only had one guy tell me you don't deserve it. So, hey, we had to leave it there, but he just didn't agree that everyone deserves equality. And I can't make him believe that. So I'm like, I think you're a great guy. I love you. God bless. I'm out. You take care.
Finding that common ground is so important. And I like how you've really expanded what the definition of finding someone who speaks the same language. So like even with the alma mater idea, that is really quite genius. Senator Hunt, you were able to build an impressive bipartisan body of support for your bill to authorize syringe service programs in Nebraska. Can you share one or two conversations without breaking any confidences that helped you break through and what caught those people's attention?
Your audience is going to hear a big theme here. It's really about the messenger. Thinking of political context. So in a political body, it's never just about the one bill that's on the docket that's up for debate right now on the floor, or the one that's coming through the committee right now that we're all talking about. At any given time, we are discussing and considering and trying to figure out how to work together hundreds of bills. And that's hundreds of community interests. That's hundreds of other panels, just like this one, happening around the country around another issue that people care just as much about. And that's hundreds of other issues that people come in with their own prejudices and their own misunderstandings about too. So it's a lot of negotiation and compromise around, I need my colleagues to know that this syringe service bill is the most important thing to me this year. So, if I have to pick out anything that we're working on, this is the one that I want to happen. So working with leadership in the legislature to make that clear to them so that when we're talking about every senator being able to go home with a win this year, this is the one Senator Hunt wants. So if she's taking it this seriously, it must be really serious, because there's a lot of stuff I care about, but I'm saying this is the one I want us to do. Our speaker, who is a different political party than me, he was a big ally and a huge help to me in getting this done as much as we did. He took the initiative to speak to conservative senators to convince them that, like, Megan's not just doing her socialist bullshit. Like, this is actually a real thing that is going to help people, even conservative people, all that type of thing. Making them understand, people who inject drugs are from all walks of life. People who struggle with conditions like hepatitis or HIV, they are from all walks of life. It's rising in all of your districts. And this is one tool in the toolbox that we can use. Yes, of course, along with prayer. Yes, of course, along with means testing and work requirements for benefits and whatever else conservative ideas that we want to do. But making sure that people have syringe service programs, we know is something that's going to help reduce the risk in our communities. And the conservatives in the body also really helped me get cooperation of law enforcement. And then that branched out, not just our local law enforcement in, say, Omaha or Lincoln, the bigger cities in my small red state, but agencies in Texas, agencies in Illinois and Ohio. We had a really great ally in Ohio who was the police chief, and he spoke to a lot of my conservative colleagues about how, no, this doesn't increase crime. It doesn't encourage law breaking, things like that. And, it was my staff, it was advocates like those in our street, it was people with like the Nebraska AIDS Project. We had a lot of hands on deck to make this possible. And I feel like so much of the work was just trying to figure out who the right messenger was for every person. And there were people who I feel like we should have reached. There were senators who I feel like I cannot believe they weren't with us. Like, I could never make them understand, no matter who I had bring them the message. But and like Ms. Newman said, at the end of the day, sometimes people just aren't going to agree with you, and they're going to go, "No, you don't deserve rights. No, I don't freaking like you, and I don't want you to have a win." And you have to realize at that point, like, it's actually personal. Like, it has nothing to do with the validity of the argument. It has nothing to do with the research and evidence that shows that these are programs that work, that reduce addiction, that reduce community harm, that reduce disease, that become public health challenges and public health epidemics. They just don't freaking like you. And it's like, okay, on to the next conversation. Like, I cannot change you. You have to choose to change at some point, and you have to realize when you're perhaps not going to win that fight, or you're going to win the fight another way by setting an example, by showing these obstinate people who have made up their minds that their mind is like concrete, it's all shaken up and permanently set, that if they see other people going along who they trust and believe, maybe that's going to be the only way to reach them. But at the end of the day, if you do your best, how can anyone ask any more of you than that, I guess?
I think especially for the folks who are in this room and on this call, I mean, doing our best every day is something that we all have to take solace in, because sometimes those wins feel like they're few and far between. I'm next going to talk a little bit about the economic impacts of HIV, and I'll share a little bit of data about that before we get into some questions. So first, in 2019 dollars, the estimated average lifetime HIV-related medical costs for one person with HIV is about $420,000. And also, according to HIV.gov, the estimated total direct expenditures for HIV and AIDS care and treatment in the United States between 2002 and 2011 was $10.7 billion, and that was each year. That's 800 to 900 times higher than similar expenditures for other chronic conditions. And finally, antiretroviral therapy, which is how you treat HIV, was among the top 5 therapeutic classes of drugs in non-discounted spending on medications in 2018. And that came in after medications for diabetes, autoimmune diseases, cancer, and respiratory disorders. So we find that economic arguments sometimes really resonate with folks who are skeptical about harm reduction interventions. So Tony, have you found success in making economic arguments or personal connections for individuals who might need to refocus on HIV?
My first argument is always inaction versus investment. If you do nothing, your young daughter, son, nephew, cousin could eventually possibly catch HIV and AIDS. So are you going to sit back and do nothing, or are we going to really invest to bring this thing to a close? I don't believe we'll get there by 2030, hopefully by 2040. But if we do nothing, we put no money there. Someone that you love very dearly, some young person coming up, could eventually become HIV positive and get AIDS. So is that your decision to do nothing? Or let's put some investments here so we can end this thing and bring it to a close. And productivity and economic impact. A lot of people say, oh, AIDS is da-da-da. AIDS is a disease. We need investments. We need productivity. We need research. That requires money. So without money, we're never going to come to find a cure for the HIV epidemic. So we need investment. And without investment, we're never going to find a cure. Going back to, would you like one of your loved ones? You have 2 daughters and a son. What if one of them caught HIV? Wouldn't you want them to get the best healthcare they can with the most recent research and drugs available so that they can manage it and live comfortably for the rest of their life? And the impact on families and communities. I said, if we don't address these people with substance abuse and mental health abuse, they're on your streets. That's a socioeconomic problem in your city. We have to get to the problem of drugs, mental health, addiction. If we don't address these things, they're just going to live on your streets. They're going to be homeless. And this is something that you say as city people live in your communities that you don't want. And the global economic stability. If we all work together to find a cure for HIV, we can bring this thing to an end. Gilead, Merck, and ViiV, great sponsors of NMAC and USCHA, which is the biggest AIDS conference in September 9th through the 12th, I must give pub, in New Orleans. We have all the researchers, all the doctors there, people with HIV, people from the community. We need research, and that requires money, because I would hate for your young daughter, son, cousin, nephew, niece to get HIV. I always try to bring it personal so that they can relate, because HIV doesn't discriminate. You think it's an LGBTQ disease, you think it's trans disease, it knows no face. It doesn't know a body. It doesn't know who's Black, who's white, who's gay, who's straight. So I always say, you never know what home it could hit, and you don't want it to hit yours. Let's invest. Let's put our money where our mouth is. And most times it works. Of course, you always have a naysayer, and then you have to do like Senator Hunt said, is shake their hand and keep it moving. You can't convince someone who's got an adamant, unable to break through, and maybe someone else can get through them, but maybe I've left them with some food for thought. So
That's all very true. And your points about how community and social determinants of health are really important to all of these, to HIV care and prevention, are well taken, and also shows how it's a much bigger problem too. Senator Hunt, since syringe service programs have a strong economic case, with significant return on investment, what role did the economic aspects of SSPs play in your conversations?
Well, with many issues, prevention is always less costly than treatment. And whether we're talking about issues in healthcare or syringe service programs or even incarceration, our carceral system, talking about the cost of locking people up versus helping them with the issues that get them system involved in the first place. All of these things are part of the same web. All of these things are part of the same universe of challenges that are getting people involved in positions of hardship. And when we're talking about something like a syringe service program, this is not actually that expensive to do. And so just breaking down for my colleagues, like, okay, when I say not that expensive, what do I literally mean by that? What does this cost? The bill that we introduced in Nebraska, which, your mileage may vary. I know that we're talking to an audience of people who aren't considering my bill, who might not have something like that in front of them. But our bill was unique because what it said was that local jurisdictions, so a village board, a city council, what have you, would have to first approve the creation of a syringe service program. And then that would be up to that jurisdiction to fund. So my bill costs nothing to the state, technically. We distributed lots of information about federal funding, federal grants, philanthropic grants that were available for syringe service programs in Nebraska, to basically outline for voters and for members of the community and for my colleagues that this is something that could be paid for, that communities were ready already. Our healthcare centers were already ready to implement these programs, and they already had means to pay for them. So this was not going to be like a big new expense to the state. And again, as Ms. Newman was saying, just talking about the cost of prevention, the cost that we pay in Nebraska per year today to treat people with HIV, to treat people with hepatitis, to also combat opioid addiction in our state, which is a scourge across this entire country, and what kind of role a syringe service program could play in helping people who are ready to cross that bridge to stopping drug use, who are struggling with addiction and are looking for help. If these programs can be the hand up, can be the bridge for our neighbors who are struggling to find that treatment, that's a public health win. But if we must make this argument, it's an economic win as well. I mean, these individuals are going to be less of a cost on my extremely generous tax-paying conservative colleagues who generously contribute to the general fund every year through the payment of the taxes that they are so concerned about. So it was important to me that they understand that, it's really not a big cost. And what's the big cost is if we continue to do nothing. It's a cost societally, it's a cost economically, and at some point they need to examine their beliefs and say, are you really against this because of you think it's expensive, or are you against it because you are harboring some misguided discriminatory views that we need to examine together? And you see on the vote count, at the end of the day, most of them ended up coming around.
I think it's always so interesting how people seem to be more willing to spend money on things that are existing than they are to spend money on preventative situations.
Yeah, and I mean, sometimes that's a concern of colleagues too. They say like, well, once we have this program, we're never going to not have it. You can't put it back in the box. And so, what if it ends up costing a lot of money down the road? They're always going to come back asking for more funding, which yeah, I mean, that is what happens with different programs that we authorize, that we put into play politically and economically. But again, what is the cost of doing nothing? What is the cost of an HIV epidemic? What is the cost of a hepatitis epidemic? What's the cost of the opioid crisis that we have in our state personally, which is impacting our smaller communities and our rural districts more than anywhere else in the state? And wouldn't you want to help these people regardless of the cost?
One will hope so. Katie, so working at a health department, your work is very reliant on getting access to funding, and that can be from the state, that can be through grants. How are you making the economic case for funding your services?
I've actually struggled more with making kind of the economic argument locally with expanding our services. And I think some of it is a distrust for science and a distrust for some of these larger institutions or CDC that came out with these statistics. So mine's almost been well, let me just show you, like, we're going to start this. And then we have a very strong evaluation component around our new clinic. So I know we will show some economic benefit and be able to show local cost savings or really demonstrate to individuals that could possibly fund us that this clinic is a worthwhile investment. Some of my struggles then with like local hospitals and, it's hard to get certain buckets of money into local public health. There's so much that goes into clinical care. So trying to change that mentality locally that we need to invest in these prevention services is a challenge, but I'm really our new clinic is literally shaking out the couch cushions to find just money in our community that could possibly fund this. It's literally the interest that was earned on the ARPA money from the city, having those ARPA projects waiting to be implemented. And that's allowing me to bring a position into our health department for 2 years. So it's really going to be showing them that this is what's going to happen. This is what your investment can do to impact our community. And then I'm really hoping that we can build or encourage people that are going to be treated at this clinic to really speak up and talk about the value of it. So again, using those messengers to really keep this going forward.
Thank you so much for that. And it's really quite amazing how much you've accomplished without having as much support as we might hope that you would have from your community. I am going to jump in and do one of the audience questions really quick. So we have a question that asks how there's a lot of information about advocacy and coordinating and connecting with representatives. But first, are there any trainings for effective advocacy? And also how oftentimes advocacy can come from emotion, which also fuels the passion of advocates. But it can affect their delivery. So how can an advocate balance their advocacy efforts between emotion and logic? Does anyone want to start with that? Tony, go ahead. I think you're on mute though. There you go.
I was going to let the other two handle this while I ponder. As a trans woman, 30 years experience, I take personal attacks out of the gamut. I don't, when I'm approaching advocacy, I'm looking at data and the law. My background is the law. I use the law and data to make my points. Because if I bring how passionate I am about being a trans woman of color with my experience, that may not be received well. So my key points for advocacy is I love the passion, but stick to the facts. Be factual. And that's something that some of the Republicans don't do. I don't mind listening to your argument, but be factual. Be data driven. Just don't make up stuff and say that this is true in a general context. So I would say keep the passion, stick with the facts, go with the data, and don't take everything so personal. I know I have a very, very thick skin. It took 20 years to build that up, but don't take everything personal. Try to meet people in the middle, try to meet people where they are. That's more of a solution to me when you're doing advocacy, coming in with a strong opinion and not being able to hear the other side, whether you like the other side or not. That's not a good strategy, in my opinion. I try to listen and try to meet them halfway if I can. A win-win is better than a loss, in my opinion. And I'll pass that to Senator Hunt.
Thank you. One thing I think advocates, especially new advocates, which I don't know if you are, but maybe someone watching this can relate. I think sometimes we put a lot of pressure on ourselves to like invent the wheel, or like we think you become aware of a problem and you think like, oh my God, I gotta fix it. And what we have to remember is we stand on the shoulders of generations of people who have been working to fix it, who have built foundations for us to move forward from, so that we don't have to do all the work ourselves. So look on the ground, look at the hyper local level at who is already doing this work, who you can join and help and contribute to. And that will release you from the anxiety and stress of that we advocates often feel. I mean, my background is in activism and advocacy, and I ended up as a lawmaker. And I've learned that there are you use different playbooks. You know, when you're on the street marching, when you're knocking on doors, when you're doing mutual aid, when you're getting people connected to assistance as a neighbor and a community member, that's one playbook. That's one rule book. But when you're inside the glass, when you're in the arena, when you're negotiating with politicians with highly diverse motivations, that's a completely different rule book. So what you need to do is learn what your strengths are. What, you know, do you have a thick skin? As Tony Newman said, as Ms. Newman said, if you have a thick skin, like she does and like I do, maybe you belong in the arena. Maybe that's where you need to be fighting, because these people won't bring you down. If you know that's not your strength, maybe you belong on the streets, where you're marching, where you're fighting, where you are bringing that passion, and you don't have to hold the passion back, so that you can motivate and inspire the next generation of activists and advocates who are going to stand on your shoulders. So take a personal inventory of what your strengths are. How do you fight? What are your vulnerabilities? How can you partner with people in your community to make up for those vulnerabilities? And be honest with yourself about where it is you really belong in the movement, because everybody belongs in the movement. There is a place for you, and you do not have to do it by yourself.
And I mean, I agree with both Tony and Senator Hunt. I do want to add that, you know, advocacy work is a long game. Doesn't happen overnight. And it's about looking for those small wins that can build upon each other to really make change in our community. So being willing to negotiate, having common sense, being, you know, respectful, working with people, understanding all of their different priorities and the different things are going on, and have those little moments where you can make a difference or get them to start thinking in a different way, which is going to possibly lead to a change. And then also don't burn bridges. If somebody doesn't do what you want them to do one year, you don't want to lose that, because people have long memories, especially policymakers and people in legislative power.
Those were all really great answers. And I feel like I am inspired from them even more so too. But just kind of to circle around through some of that, I mean, I think we're talking about the importance of incremental policy change in some cases here. You know, finding that middle ground where we can move a step forward and hopefully the next legislative season move another step forward. And then I think the importance of evaluation, like Catherine was talking about in public health, is so important, because then you can show that your program worked and that it was good for the community. We have just a little bit more time left, and I wanted to just quickly ask you all to ring in and say, like, where do we go next for policy at the federal and the state level? Whoever wants to jump in first can go first.
I can begin, because I cannot speak as an expert here. So I can't be the one to say, here's what's next for, you know, policy around this. But what every person needs to do, whether you can vote or not, you have a stake in what this country and what your community can provide for you. We all need to ask every candidate for office, from city council to Congress, all of it. What are they doing to address HIV prevention? What are they doing to take public health seriously, you know, in kind of a big picture way? What are they doing to respect the work of scientists and doctors and researchers who are investing their lives to keep us safe and healthy. Because we should not have people on the ballot where we don't know what their positions are on that kind of thing. Because that's how we get into the position that I'm in the legislature, where I'm working with people who are well-meaning, who want to represent their people, but who are willfully ignorant, proudly ignorant. And we just simply cannot be electing these people anymore. We got to change who's in there.
I would just like to add, get out to vote. We have the Get Out to Vote campaign starting in September with the HBCU tour. Your vote matters, and it's not just at the president level. You should be looking at who's your city council, who's your senators, who's your state house people, because those are the people really controlling your life. I live in Hollywood Hills. I know my representatives. I know what they stand for. I know what they represent. If you want to change the impact of your life, use your God-given American right to vote and pick the candidate that closely aligns with your belief system, what you consider to be morally fair and equitable. Make sure you vote on November 4th, from the bottom of the ticket to your mayor, to your city council, to your senators, all the way to the president of the United States. I'm not telling you who to vote for. I'm not going to tell you who I'm going to vote for, but I am going to use my American citizen right to vote. And I think that's the key. If you're an average citizen and you don't know what to do, vote on your November 4th ballot from the bottom to the top. Make your voice heard, because you never know. You could be the one ballot that kicks your candidate over the top. I mean, you could. I know that's a rare scenario, but it probably never happens with 7 million people in California. But as we say, you never know. So please use your vote. Use
It
your
happens in
mouth.
Nebraska.
Well, and you know, it's never happened in California. That's my voting state, where, oh, they won by 1 vote. I know people like, oh, my vote doesn't matter. I'm one person. You never know. And that's your American right to vote. So utilize that. Utilize that.
Catherine, do you have anything to
And
add?
I'm gonna have to get on that voting bandwagon. And it's for you to vote, but it's also work within your communities to vote, because so often the individuals that we impact the most in public health are the least likely to vote. We just had a mayoral runoff election 2 weeks ago, and only 12% of our registered voters in the community voted. And if we could have gotten, you know, communities that are traditionally disenfranchised voting, we probably would have had a different turnout or a different mayor. And it's so key for all communities and everybody to really, you know, vote, especially in those local elections, because that's really impacting your daily life, even more so than who's president. So I really, from a local level, I really encourage people to vote for those local officials.
All right, everybody. I will also echo that voting is so important, especially up and down the ticket. So with that, I am going to wrap it up here a little bit before our intended time, but I wanted to thank our panelists so much for joining us. You all were so inspiring, and your work is so important. And I am just grateful that you took the time out of your day to spend it with us. And to all of our audience, I'm also grateful that you took some time out of your day to spend it with us. Thank you so much.